Hello and welcome to For Kids' Sake with Dr. Lance Chilton. I'm your host, Rosalinda Roman, and if you are new here, you are in for a treat. This is a wonderful show. It is dedicated to the health and well-being of children. Every episode, we tackle hot topics relating to that, and today is no different. So we're going to focus on the disparities in health and healthcare for children, and we're also going to be talking about premature infants. So two very important topics within the healthcare field, and of course I'm joined with Dr. Lance Chilton. Hello.
Hi there.
For those of you that are new here, I wanted to introduce you to Dr. Chilton. He is a passionate advocate for children. That's the number one thing I think we can say about you.
Thank you. I like being an advocate for children at the state level with the National Academy for Pediatrics and around the world if I can.
Which brings me to your actual title. You're a pediatrician.
That's right.
Which is kind of important. We also, one of the other things that I think people may recognize you from is that you do a column in the Albuquerque Journal every other week, and it's a place that people get to ask you questions, right?
Yes, I like answering questions in my practice and also in the paper and maybe even here on the air.
Yeah, and that's really what this show is all about. We bring on experts and talk about different topics. And today's topic, the main topic we're going to talk about is, are the things that adversely affect children's overall well-being.
Yes, those things that lead to disparities in health between those children who are advantaged and those who are disadvantaged in one way or another.
And New Mexico is kind of a unique place. Overall, we call it the land of enchantment because it is so enchanting. But as far as healthcare is concerned and the effect different factors have on kids, how does New Mexico compare to some of the places you've been?
Well, if we define healthcare broadly and talk about the overall well-being of children, New Mexico doesn't do very well, largely because kids are so poor here in this state. But compared to Mexico or Sri Lanka or Nepal, where I've worked, there are more resources. There are many more resources than are available in those places. So we're sort of in between the mass of the United States and the third world.
So we're really fortunate to be in the U.S., but we do have some real challenges here in New Mexico.
Yes, we do.
And we are going to talk to you about that in further detail coming up in the next segment. But we also, what I like about the show is you bring on experts. And today, the expert we're going to have with us is Dr. Sara del Campo de Gonzalez. She's another pediatrician who's going to talk about these issues as well.
Yes, Dr. del Campo de Gonzalez is the director of the Pediatric Advocacy Program, teaching faculty and residents and students at the University of New Mexico how to be advocates for children, how to get around some of these problems that adversely affect children.
And even just talking to her off air, I can tell we're going to have a great conversation. So people have to stick around for that. But the show has more than that. You also go out and talk with residents about different issues.
I talk with residents every day anyway, of course, but Ann Kirk, who's one of our residents and who's done some great work starting to improve the care given to premature infants once they leave the hospital, will be talking with us about those efforts.
And what the advances that have been made in caring for premature infants is amazing. So I look forward to hearing more about that.
Good.
Yeah. And then talking about something we look forward to, the final segment is kind of your pet project that you really enjoy, getting out into the community and talking to parents.
Well, it allows this project, which gets us out into the libraries and the branch libraries around Albuquerque, highlights these wonderful resources and the reading that goes on there. I think reading is very important, and being able to combine that with answering questions, which I like doing anyway, is really a treat.
It really is a treat, and for us, because we get to sit in on that. So I hope everyone will stick around till the end of the show. But for now, I hope everybody's going to stick around until the next segment. We will have Dr. Sara del Campo de Gonzalez and Dr. Chilton talking about the children's overall well-being and the factors that adversely affect that well-being. So please don't go away. Welcome back to For Kids' Sake. So the way that we raise and care for our children when they're young has impacts all the way into adulthood. I think most of us who are parents know that, and that's what we're all afraid of, is messing that up. But luckily, we have experts to turn to when we have questions, and that's what this show is all about. We have two experts today to talk with. Of course, Dr. Lance Chilton, who is here always answering our questions. But we also have pediatrician Dr. Sara Del Campo de Gonzalez to talk with us today. And we really want to talk about some of the factors that adversely affect the overall well-being of a child. We talked briefly in the previous segment about obviously financial concerns are a factor, but what else is there that we need to be worried about?
So we talk about this term, adverse childhood experiences. Would you tell us what that means and what some examples of that are?
Sure. So when we think of adverse childhood experiences, we're trying to get a sense of different categories of experiences that kids have had, whether it has to do with abuse, neglect, or household dysfunction. And with household dysfunction, that could mean a parent who is incarcerated, maybe a family where a caregiver has mental illness or substance abuse issues. And so we start to tally up how many childhood experiences that were adverse, and there was a large study done where they were able to link the more adverse childhood experiences that you had to poor outcomes related to health, related to behavioral well-being.
So you'd expect that there would be adverse consequences of adverse childhood experiences in the emotional realm. But that study, I think it was done in San Diego a number of years ago, showed effects long beyond those emotional effects, right?
Right, exactly. And so you saw adult effects, whether they were related to emotional well-being, but also related to biological or healthy outcomes, higher rates of cardiovascular disease, diabetes, things like that. That sort of ties into the idea of toxic stress, which when kids are experiencing lots of adversity in their life, if it is prolonged and if it is frequent and they never have a chance to kind of recoup back to a lower level of stress, we're finding that that can have long-term outcomes for health and for emotional well-being as well.
So all of us are exposed to stress at times, but toxic stress is different than that, right?
It is. It's different. There are different categories of stress, like you mentioned. There's just your normal stress that can be positive, and it is essential to development. A child is rightfully afraid of getting poked at the doctor's office, but the mother or the father is there to offer them some consolation, and they return to a regular state of no stress. Then there's a category called tolerable stress, where now it's a larger stress. Maybe they broke an arm, it's something very traumatic to them. But again, they have that relationship, that stable relationship that brings them back down to a regular level of stress. And then toxic stress is just sustained stress. They're in fight or flight mode all of the time. And they never have that stable relationship to kind of anchor them.
And this is something that you're talking about, like if somebody's in an abusive home, or maybe they don't have a home to go to.
Right, exactly. And so we have to think about what are all of those sort of contextual things that can lead a child to feel at a higher level of stress all of the time. And it can be things like housing, not having a stable home. It can be things like poverty, food insecurity, not having knowledge of where your meal is going to come from every night, or being hungry after you've eaten. Lots of different things that we don't always think about.
So if a child has had this toxic level of stress for prolonged periods of time, say they had, a traumatic experience. One of my daughter's classmates his mother was murdered, for example. This is a deep impact. How do you recover from that? What can be done to to maybe give them a fighting chance?
Right. Well, we know that all hope is not lost. You know, if you can, with the knowledge that a stable, secure relationship can remedy some of those effects, you know, you try to give the child a good, supportive network, whether that's in their own family or the community around them. That's why there is a lot of really good research coming from mentorship programs or things that connect children in poor socioeconomic status or maybe with a poor outcome with somebody who can mentor them through that experience. And then, you know, you definitely have to invest in prevention strategies. What could have helped to develop the context so that that would not have happened for that child, and prevent that it would repeat itself.
So that would explain what you're doing with respect to advocacy. Children don't vote. Too bad.
Right.
And so you're working with pediatric residents, pediatric faculty, pediatricians around New Mexico to improve how the state serves children. Is that correct?
That's right. We have a training program through the University of New Mexico for pediatricians that come from all over the country. But one of the components of their training is to learn how to advocate for patients, and also to learn how to find out what the needs of their community are, what are the resources in their community. What you should be asking other than symptoms of an illness, what you should be aware of when a patient did not take their antibiotics. You should be aware that they didn't have electricity to store the amoxicillin in the refrigerator or whatever the case is. So it's a training, it's a change in culture about how we ask things, but it's also kind of giving them the tools to talk to decision makers.
And I've noticed that the questions have changed from just in the 10 years since my first daughter was born to my 3-year-old. The questions are changing. They ask different questions when you bring your child in,
Right.
And that's nice. That means that some of these things that you're talking about are having an impact.
Right. That's exactly right. I was very pleased yesterday. I was precepting a resident clinic, and the patient came back and said, I think that this family needs legal assistance because it turns out that the landlord will not clean the carpets and the child has horrible allergies and it's provoking asthma attacks and things. And I said, bravo, you asked about the living conditions and the carpets, and you know, so it's taking them to another level of understanding about their patients and where they're coming from.
So there's individual advocacy, such as in that situation, and then there's advocacy for children as a whole, and you're doing that too, right?
Right. So, right. Trying to teach residents that there are different levels. There's in your clinic, what can you do within the walls of the hospital or the clinic where you work? And then what can you do within your community? And we're pretty fortunate in New Mexico that our legislators are relatively accessible and very open to hearing our thoughts about childhood health issues. But then we're also, you know, a few of them get to go to Washington, D.C. with me and learn about federal advocacy efforts, you know, that trickle down to our state and benefit us as well.
The children certainly benefit from this kind of approach. Do you think that the residents benefit from it as well?
I think so. I think that they get a better experience. They've, you know, a lot of us went into medicine with the personal statement written that says, I want to help children and change the world. And I think that we get bogged down by working so many hours in clinics and in hospitals. And so it's nice to make that connection with families on this personal level of let me help not just you in the clinic visit, but let me help your situation at home.
It's excellent to see that impact, not just on the families with the kids, but also on the future of medicine, which is very exciting for those of us that have kids.
Right.
Perhaps we can make a difference in reducing adverse childhood experiences over time and make the outcome for children and for health better overall.
Right.
Well, we really appreciate you coming on and joining us in this conversation. It's such an important conversation. You're obviously doing great work. So thank you so much for joining us.
Thank you for having me.
Thank you, Sarah.
Thank you for having me.
And thank you to those of you who are watching. I hope you will stick around until after the break. We are going to have Dr. Chilton and Dr. Ann Kirk discussing the caring for premature infants. Obviously, another hot topic, lots to discuss, and lots of changes in that medical field. So I hope you'll stick around.
Everybody has a dream. Mine was to see the ocean. And with a little help, I made it.
Well, with the medical technology available today, premature babies stand a much better chance of survival than probably ever in history, I imagine.
That's true.
And so that's why this topic that you're about to talk with one of the residents is so important, because there are major changes.
Yes, there are many more babies surviving these days, and they need to be taken care of with considerable care because they present different problems than we're used to seeing with term babies.
So you talk with one of the residents. Can you tell me about her?
Yes, Ann Kirk is a resident who comes to us from Texas. She and one of her faculty members have devised a program to tell the rest of us, to help the rest of us provide better care for premature infants once they leave the hospital.
Excellent. So let's check in at the University of New Mexico Pediatric Clinic and talk with Dr. Ann Kirk.
Hi, I'm here with Dr. Ann Kirk. Ann, thanks so much for joining us today.
Thanks
and
for having me.
You're welcome. We are talking about prematurity, which is a particular interest of yours, I think.
Mm-hmm.
Tell me, are premature babies more common these days in New Mexico?
So in the data from 2011 shows that about 1 in 9 infants were born premature or preterm, which means they were born less than 37 weeks gestation. This is about 11.8% of the babies born in New Mexico. Actually, since 2001, so over the last 10 years, this number has decreased by 5%. And the reason why it's decreased is actually we're discouraging more elective delivery, so inductions and elective C-sections, and doing them more for medical reasons. Also, we're discouraging smoking in mothers that are pregnant, and that's decreasing this number. Another thing that we're doing is we're reducing the number of embryos transferred from during fertility treatment. So there's fewer multiple births, which brings this number down.
Well, it's wonderful that the amount is decreasing. Prematurity is associated with a number of problems, right?
Yeah.
Can you tell us a little bit about those?
Yeah, so there's a lot of complications with prematurity. There are some immediate complications with prematurity. So these include breathing problems. So the babies can have respiratory distress syndrome, which means they just don't have enough surfactant and their lungs are just very immature. They can have apnea of prematurity where they stop breathing. They can also have heart problems. So they can have a patent ductus arteriosus, which is a connection within the heart that remains open when it should close after birth. There are many other problems. There's infection, which is a really high risk in premature babies. So you can have infection in the gut, which is necrotizing enterocolitis, which can cause a lot of gut abnormalities. They have problems with glucose control, so they can have high blood sugar, low blood sugar. They can have a lot of different problems. And these translate into long-term complications as well.
Tell us a little bit about those long-term complications. What do you see after babies go home from the hospital?
Right. So after they go home from the hospital, the things that we tend to worry about is they can have a lot of behavioral problems. They can have developmental delay. So they can have problems with cognitive impairment. They can sometimes have cerebral palsy, or they can have gross motor or fine motor deficits as well. A lot of times they can have hearing loss. Or vision problems. So all these things we really need to think about when we discharge them from the hospital.
And so now we're getting to the subject of this grant that you've recently gotten. Congratulations on getting this grant.
Thank you.
You and Dr. DuPont are going to be looking at babies once they leave the hospital and trying to help the parents and also the physicians around New Mexico improve the care, right?
Right, exactly. So the goal with the grant is to kind of follow these patients after they're discharged. Make sure that their primary care doctor knows how they're different than a normal term infant born on time. And so it's really important to have education and communication with the primary doctor and with the parents. So we want the parents to know why the kid needs to go to their eye appointment, why they need to follow up with specialists. And I think that what we're developing is called a neonatal passport, which is a way to communicate these important things that need to be communicated with the primary doctor and also with the parents.
So the passport isn't to get them on the plane,
No.
but rather to help them develop better care
Right.
around the state.
Right.
There's sort of a disconnect between the care that newborns need and trying not to make parents worry too much about the babies. How do you handle that disconnect?
I think the most important thing in what we're trying to do with the neonatal passport is communication and education. So I think if the parents understand why they need to go to the eye appointment, what the risks are, then they will go to the appointment and they won't worry as much about their child. I think a lot of parents don't know what to expect when they go home, so having something like this passport will give them important information about what they're going to be doing after they're out of the hospital, and I think hopefully that will make them worry a little bit less.
And so those of us who are taking care of them, those of us pediatricians who are out in the community, will have an idea too for that 11.8%, what we should be doing for them, right?
Exactly, and I think one of the important things that we want to convey in the passport is to correct for gestational age. So these kids are born quite premature, so we actually have to calculate their age based on their actual delivery date, and then based on those we calculate their developmental milestones, so when they should be doing things. So they actually, based on the age they were born, their chronological age, they will actually be hitting their developmental milestones later than normal kids born on time. So we need to correct for these things so that the primary care doctor isn't expecting them to crawl at an age when they shouldn't be crawling yet because of their prematurity.
Well, let's give an example of that. Suppose a baby is born 2 months early, and when should they crawl then?
So a normal baby will crawl at 9 months. A baby born 2 months early would crawl 2 months later than that, so at 11 months.
So 11 months.
Yeah.
And we shouldn't consider that abnormal then?
We should not consider that abnormal. We actually should correct for gestational age up to 2 years of age. So they will actually get their shots at their chronological age, or depending on when they were born, they will get the shots at the same ages as kids born at term, but their developmental milestones will be delayed because of their prematurity.
Prematurity is really an important problem, and I greatly appreciate your coming and talking with us about this today.
Thank you.
Good luck with your grant.
Thank you.
And when we come back, we're going to have questions and answers to questions about your baby's health when we head out to the library with Dr. Chilton.
What to do, what to do? Movies! To do or not to do?
Need a little culture? Check out the new online calendar and plan your night out on the town. Find film festivals, club events, and live theater. There's more to do in ABQ. abqtodo.com.
Well, I get the feeling you love your job no matter what you're doing, but one of your favorite parts of your job is dealing with parents, interacting with parents and kids, and you get to do that by going out to the libraries, right?
I love libraries, for one thing, and I love answering people's questions. So today we talked with a bunch of parents about the questions that were on the top of their minds.
And which library did you go out to?
We went to the Tony Hillerman Library, which is a wonderful place named after a wonderful person who's no longer with us, and where we can find excellent librarians, lots of books, and a whole lot of children and parents.
Awesome. Let's go check it out.
So I have 5 kids, and just to get this questions time started, start with a question about going to the bathroom. I have 2 in particular that struggle a lot with constipation, and I've tried a lot of things. One of my pediatricians from back home had me have one of them on Miralax for about a year. Finally weaned him off that. We've been doing a lot of different things, a lot of water, a lot of focusing on trying to go every single day, but it's just a constant problem. And I was wondering if you had any more suggestions, since it's something that one of my kids, if he doesn't go to the bathroom, it's to the point where when he wakes up in the morning, he throws up, he gets sick. So that's why it's a concern.
I think it's a really important problem that many people underestimate, so I'm glad that's the first question.
Sorry, like
No,
I said, it's not a glamorous question.
not a glamorous question, but it's sure part of my day every day.
Yeah.
I think that children who don't go to the bathroom on a regular basis and have hard bowel movements have pain with it, and it's a vicious cycle that keeps getting worse.
Yes.
So I have only suggestions, and
Great.
So diet, I think, is probably the most important part.
Okay.
Getting your child to eat more fruits and vegetables, and
Okay.
particularly things that have a lot of fiber. So whole grains, whole wheat, brown rice rather than white rice,
Okay.
oatmeal. Those are very helpful things. And then if that isn't working, if your child is still having hard bowel movements, it really doesn't matter how often it is, as long as they're soft and unpainful.
Okay.
But if your child is still having hard bowel movements, then I think it's time for you to talk with your doctor about getting something like Miralax or another medicine that I use a lot called lactulose to help them have a regular bowel movement.
Okay. All right. We definitely have tried some of the diet things, and I've used Juice Plus too. It's kind of, I don't know if you've heard that. It's like a supplement kind of.
Yeah, I think that's worthwhile too. People talk a lot about prune juice, and probably that's good if you can get your child to take it.
Okay.
Funny taste, isn't it?
Okay. All right. Well, thank you so much.
Sure. Thanks for asking the question.
Yep.
Okay, I am a mother of twins who are entering kindergarten this year, and I just wanted your perspective on whether they should be kept together in the classroom or separated, because at home they're very dependent upon one another, but they've always been together because I'm a stay-at-home mom, so they haven't known anything different.
That's a great question. I am the grandfather of twins also, and they are now 10, and they started out in school in the same class for the same reason, that they're very much dependent on one another. People talk about twins having their own language, you know, that do yours?
They do,
They
definitely.
do, and we're sort of left out of that, right? But they really did depend upon one another. When they got to about 3rd grade, they were sort of getting in each other's hair and in the teacher's hair too, and so it seemed like it was time then to separate them. But I think if they are dependent on one another, I would suggest they're being in the same classroom, and then watch as things go and talk with the teacher. It's always good to talk with a teacher about your kids, no matter whether they're 1s or 2s or 3s or whatever, but find out if it seems like their being together makes their education better or worse.
Great, thank you.
Mm-hmm.
I just love the fact that you could go to a library and access information from a doctor in person. Modern days. All right, well, thank you for joining us, and thank you for joining us here on For Kids' Sake. I hope you have enjoyed the show and all the information from Dr. Lance Chilton. It's always a pleasure. And until next time, I'm Rosalinda Roman.